Hello and welcome. We will start from where we left in the last part. Let's start. The learning objectives are shown. Please take a look. The only drug is metformin and is often the first-line therapy in type 2 diabetes. Its primary effect is to activate the enzyme AMP-activated protein kinase, AMPK, and reduce hepatic glucose production as is discussed in the next slide. As a consequence of metformin's blockade of gluconeogenesis, the drug may impair the hepatic metabolism of lactic acid. In patients with renal insufficiency, the biguanide accumulates and thereby increases the risk of lactic acidosis, which appears to be a dose-related complication. Because metformin is an insulin-sparing agent and does not increase body weight or provoke hypoglycemia, it offers obvious advantages over insulin or sulfonylureas. It also decreases the risk of macrovascular as well as microvascular disease. This is in contrast to the other therapies, which only modified microvascular morbidity. It is indicated for use in combination with insulin secretagogues or thiazolidinediones in type 2 diabetics in whom oral monotherapy is inadequate. This diagram shows major sites of action of metformin. AMP-activated protein kinase is an enzyme that functions as a master regulator of cellular energy homeostasis, sensing low energy states and activating processes that generate energy while inhibiting energy-consuming processes. It is activated by high AMP or ADP to ATP ratios, promoting fat and glucose uptake, fatty acid oxidation, and mitochondrial biogenesis, and inhibiting fat and protein synthesis. Summary of a selection of target proteins and metabolic pathways regulated by AMPK. Anabolic pathways switched off by AMPK are shown in the top half of the wheel, and catabolic pathways switched on by AMPK in the bottom half. Where a protein target for AMPK responsible for the effect is known, it is shown in the inner wheel. A question mark indicates that it is not yet certain that the protein is directly phosphorylated. As mentioned, when activated, the AMPK leads to fat and glucose uptake, fatty acid oxidation, and mitochondrial biogenesis, and inhibiting fat and protein synthesis. Visit the shown references if you are interested in further details. The most common toxic effects of metformin are gastrointestinal, anorexia, nausea, vomiting, abdominal discomfort, and diarrhea, occurring in up to 20% of patients. They are dose-related, tend to occur at the onset of therapy, and are often transient. Metformin interferes with the calcium-dependent absorption of vitamin B12 intrinsic factor complex in the terminal ileum, and vitamin B12 deficiency can occur after many years of metformin use. Periodic screening for vitamin B12 deficiency should be considered, especially in patients with peripheral neuropathy or macrocytic anemia. Increased intake of calcium may prevent the metformin-induced B12 malabsorption. Lactic acidosis can sometimes occur with metformin therapy. It is more likely to occur in conditions of tissue hypoxia when there is increased production of lactic acid and in renal failure when there is decreased clearance of metformin. In addition, acute kidney failure can occur rarely in certain patients receiving radiocontrast agents. Hence intake should be temporarily stopped on the day of radiocontrast administration and restarted a day or two later after confirmation that renal function has not deteriorated. Renal function should be checked at least annually in patients on metformin therapy, and lower doses should be used in the elderly who may have limited renal reserve and in those with eGFR between 30 and 45 ml per minute per 1.73 square meter. Peroxisome proliferator activated receptors, including alpha, beta and gamma subtypes, are related to the steroid and thyroid superfamily of nuclear receptors and are found in muscle, fat, and liver. This diagram shows major sites of action of thiazolidinediones. PPAR gamma receptors modulate the expression of the genes involved in lipid and glucose metabolism, insulin signal transduction, and adipocyte and other tissue differentiation. Thiazolidinediones are ligands of peroxisome proliferator activated receptor gamma, and act to decrease insulin resistance by increased expression of glucose transporters GLUT1 and GLUT4, decreased hepatic glucose output. It also leads to decreased release of free fatty acid levels, increased adiponectin and decreased release of resistin from adipocytes, and increased differentiation of preadipocytes to adipocytes. Additionally, also been shown to decrease levels of plasminogen activator inhibitor type 1, matrix metalloproteinase 9, C-reactive protein, and interleukin 6. Fluid retention occurs in about 3 to 4% patients on thiazolidinedione monotherapy and occurs more frequently, 10 to 15%, in patients on concomitant insulin therapy. Heart failure can occur, and the drugs are contraindicated in patients with New York Heart Association Class 3 and IV cardiac status. Pioglitazone has some PPAR alpha as well as PPAR gamma activity. It is absorbed within 2 hours of ingestion. Although food may delay uptake, total bioavailability is not affected. Absorption is decreased with concomitant use of bile acid sequestrants. Pioglitazone is metabolized by CYP2C8 and CYP3A4 to active metabolites. The bioavailability of numerous other drugs also degraded by these enzymes may be affected by pioglitazone therapy, including estrogen-containing oral contraceptives. Additional methods of contraception are advised. Pioglitazone is approved as a monotherapy and in combination with metformin, sulfonylureas, and insulin for the treatment of type 2 diabetes. Pioglitazone lowers triglycerides and increases high-density lipoprotein, HDL, cholesterol without affecting total cholesterol and low-density lipoprotein, LDL, cholesterol. In contrast, rosiglitazone increases total cholesterol, HDL cholesterol, and LDL cholesterol but does not have significant effect on triglycerides. These drugs have been shown to improve the biochemical and histologic features of non-alcoholic fatty liver disease. They seem to have a positive effect on endothelial function. Pioglitazone reduces neo-intimal proliferation after coronary stent placement, and rosiglitazone has been shown to reduce microalbuminuria. Osteoporosis, anemia and weight gain are other side effects of chronic use. Although hepatotoxicity is rarely linked with pioglitazone or rosiglitazone use, the liver function tests should be performed prior to initiation of treatment and periodically thereafter because of a potential class side effect of hepatotoxicity which was seen in troglitazone, the first agent of this class of drugs, now withdrawn. Rosiglitazone has shown some adverse cardiac outcomes and hence is not a preferred drug. Glucose is freely filtered by the renal glomeruli and is reabsorbed in the proximal tubules by the action of sodium glucose transporters, SGLTs. Sodium glucose transporter 2, SGLT2, accounts for 90% of glucose reabsorption, and its inhibition by this class of drugs causes glycosuria and lowers glucose levels in patients with type 2 diabetes. Canagliflozin reduces the threshold for glycosuria from a plasma glucose threshold of approximately 180 mg per deciliter to 70 to 90 mg per deciliter. It has been shown to reduce HbA1c by 0.6 to 1% when used alone or in combination with other oral agents or insulin. As a class effect, glycosuria may predispose to urinary tract infections especially in diabetics, especially among females. However, the concurrent loss of sodium probably contributes to a protective effect from death due to cardiovascular causes, including heart failure, myocardial infarction, or stroke. They also reduce bone mineral density and contribute to pathological fractures after chronic use. Cases of diabetic ketoacidosis have been reported with off-label use of SGLT2 inhibitors in patients with type 1 diabetes. Type 1 patients are taught to give less insulin if their glucose levels are not elevated. Because type 1 patients on an SGLT2 inhibitor may have normal glucose levels, They may either withhold or reduce their insulin doses to such a degree as to induce ketoacidosis. Therefore, SGLT2 inhibitors should not be used in patients with type 1 diabetes and in those patients labeled as having type 2 diabetes but who are very insulin deficient and prone to ketosis. Alpha-glucosidase inhibitors reduce the postprandial glucose spikes by 30–50% by delaying the digestion and absorption of starch and disaccharides. There is no effect on lactase. Adverse effects commonly include flatulence, diarrhea, and abdominal pain due to passing undigested carbohydrate in the colon that is then fermented by bacteria into short-chain fatty acids, releasing gas. These adverse effects tend to diminish with ongoing use because chronic exposure to carbohydrate induces the expression of alpha-glucosidase in the jejunum and ileum, increasing distal small intestine glucose absorption and minimizing the passage of carbohydrate into the colon. Cholecyval M hydrochloride, the bile acid sequestrant and cholesterol-lowering drug, is approved as an anti-hyperglycemic therapy for persons with type 2 diabetes who are taking other medications or have not achieved adequate control with diet and exercise. The mechanism of action is presumed to involve an interruption of the enterohepatic circulation and a decrease in farnesoid X receptor (FXR) activation. FXR is a nuclear receptor with multiple effects on cholesterol, glucose, and bile acid metabolism. Bile acids are natural ligands of the FXR. Additionally, the drug may impair glucose absorption. Adverse effects include gastrointestinal complaints, constipation, indigestion, flatulence. It can also exacerbate the hypertriglyceridemia. Here is a comparison of treatment benefit in terms of reduction in HbA1c as well as mortality and morbidity, citing various published research articles. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!